Hi, good morning. We're going to get started. We have a couple of great presentations today. I just want to introduce myself. My name is Diane Haywood. I am one of the working group members who put together a set of clinical practice guidelines for the delivery of contraceptive services for nurses. And in support of those guidelines, which you can get a copy on the website, CERC's website, www.serc.mb.ca. In support of the rollout of those guidelines, we've put together a couple of telehealth sessions, and today is the second of those, and we have a couple of wonderful presentations. There's quite a bit of content, and we're absolutely going to have time for questions. I'm super excited today because last time we had a huge number of technical difficulties, and today it is 10 o'clock, and we are rolling along, and I can see I have been trying to keep count, but I think we have around 15 to 20 sites across Manitoba who have dialed in and are going to be watching this presentation. So in the interest of time, I'm not going to go around and check who all the sites are, but during the question and answer period, we will absolutely be trying to get in some from all across Manitoba, some questions in. So our presenter today for both sessions is Dr. Helen Pymar, and as I was preparing this, I asked her, could you send me a little bit of information about yourself, and she offered to send me her CV, which I think might take me, way too much time, but I was absolutely impressed when I read the information she sent me. Not only has she contributed to writing various chapters for the Canadian Contraceptives consensus, being a member of Canadian Society of Obstetrics and Gynecology, supporting residents, director of ambulatory care at Women's Hospital, and also doing some research regarding contraception and dosages is what I got from reading. So without further ado, I'm going to invite up Dr. Pymar here to begin our discussion on the update of long-acting reversible contraception options here in Canada. I'm going to get you some water.
Yeah, that'd be great. Thank you.
I will do that.
So I'm going to apologize in advance. On Friday, I started getting a sore throat, and I'm holding out hope that I won't croak too much up here. I really thank you for the opportunity to come and speak today. I think it's really important to disseminate a lot of the information that's out there, and I really hope that I can encourage more women to choose the long-acting reversible contraceptive methods in the future, especially as more are becoming available, because I also do terminations of pregnancy, and it seems like either people who are on the pill, which is one of the most common things that we use, who forget pills, they run out of pills. If we can try to give them a method that they don't have to think about quite as much, I'm hoping that we can reduce some of our unwanted pregnancies here in Manitoba. And they're doing this everywhere, so across the world. Just going to start here. So you'll notice that some of the things that I've done involve the Association for Reproductive Health Professionals. They're a really good resource for patient teaching, and I encourage you to look over their websites. And so I did borrow quite a few of their slides, and I have some of these that I've used from other ones. Basically, if you see a little Canadian flag, then they're probably not ARHP because they are US-based. But the Canadian flags, I tried to get a little bit more of the Canadian perspective as well. So I'm trying to give you some Canadian stats, but some of the other stuff, especially related to Implanon, because that's been available in the United States for quite a while, are from the ARHP. And you'll see it as it goes along. So right now, as I'm sure you're aware, Implanon or Norplant, all those implants that we once had Norplant, but we've lost it for over 10 years, is no longer available in Canada. So it's not even on the list in terms of the most common contraceptive methods currently used in Canada. If you look at, this is from 2006 Contraceptive Awareness Project, where they called women and asked them what birth control method they were using, and they diversified it by age or stratified it by age. It didn't even show up on the radar, IUDs, until you get to the 20 to 29 age group. And then you're looking at a measly, 3-4% across the board. So even though this is a highly effective birth control method, pill is still up there in the majority of patients that are on birth control pills, using that as their primary contraceptive method. None is still pretty big. And condoms are still pretty big as well. And while I certainly support condom use, ideally I would like it in conjunction with a better method. This is talking about current contraceptive use by marital status. So the blue is married or common law, and the red is other. And again, it just shows you how OCs and condoms pretty much go across the board in terms of what women are using in Canada currently. Part of that may be if you look at contraceptive awareness. When you've asked women, what are you aware of in terms of the methods, OC and condoms are right up there. They're the top. So it kind of makes sense that they're some of the most commonly used methods. So part of what we may have an issue with is women don't even know about these methods. So IUDs, only half knew about them. So if we could increase the number to 100%, we could potentially at least double the number of patients that actually chose it. Implants, again, 28%. I can see why implants aren't people aren't as aware of implants, because they're not available in Canada. But certainly if they're reading American magazines, they should be hearing about some of these things along the way. I like to use, when quoting to students, the typical pregnancy rates, not the perfect pregnancy rates with the different birth control methods. And these numbers have gone up since I've been in training and sort of gone beyond. I used to say maybe 3% risk of pregnancy per year for birth control pills, and I like to call it pill patch ring. I like to just kind of make it all one word. Thank you. So even though the numbers for perfect use are 0.3, your general population, the numbers are 8% in terms of pregnancy rates. And then you get these patients that say, I don't understand, I took it perfectly. There's studies that suggest that women think that they're taking it perfectly, but they're actually missing pills that they never even, or they're late for pills and they never even realized that they were. So if they're putting it in a diary, they're writing, yeah, I took it same time every day. But if you look at something that actually shows when they opened up their pill pack, it showed that they really weren't taking it correctly, even though they thought they were. So I think that the fewer times you have to remember to use your birth control method, the more likely it is to be effective. And you'll see as you get to Depo-Provera and then things like the IUD and the implant, the typical and perfect become much more close together because there isn't as much room for error. You don't have to think about something every day. Even though patches are once a week and NuvaRing is once every 3 weeks that you have to remember to insert and remove, there's not enough of a difference to say that it's actually more effective than the pill. So certainly it makes sense, but there's still the things, and I think some of the reasons that they don't end up doing it, a lot of the times that I see patients that come to me, it's not so much that they necessarily remember or forgot to take pills, it was that they ran out and they didn't have a way to get more. So that's the same issue with your patch and your ring, is if you've run out of them or you don't have them in your purse or you went away somewhere, those are the types of situations where if it's always in your body, you don't have to think about it quite so often, or you only need it once every 12 weeks. But the more you have to think about it, the more likely it is to fail for you. The other thing with birth control pills is about 18% of OC users discontinue by 6 months, and 46% of those are related to side effects. So the thing that we need to do in terms of making new contraceptive options is try to improve those side effects so that women aren't stopping them because of that. And again, pills afford a much easier way to stop your birth control method. You just stop taking it because you don't like them, and your provider really doesn't know that that's happening unless the person calls you and says, I'm not happy with this method. They can stop them, and then they come back with an unwanted pregnancy is the first time that we see them afterwards. We send them off thinking that they're perfectly happy with their method and that everything's going fine. So we still need more. We still need more methods. We still need better methods. And I would say we still need methods that you don't have to think about quite as frequently. So this is just going over the ARHP and thanking all the people that did help make these slides. So what are we going to talk about today? I'm going to focus initially on the implants because I'm really excited that we have a new method that will be out there. I don't know when. Ideally within the year, maybe a couple years. It's been in the States for a while. It just takes a while to get through the Canadian red tape. And when it comes, I'd like us all to be prepared for it so that we can hit the ground running and start offering this to our patients as quickly as possible. So at least you've heard of it. And then if you know in 3 months it's coming, you can kind of promote it to your patients as another option down the road. So we're going to specifically talk about why another contraceptive method, why implantable, and why is it among the most effective options out there. And then some other things we're going to talk about is advantages of the contraceptive implant, some selection criteria, who's a good candidate, and some side effects. And that's the main negative. Of course, every single birth control method out there seems to have side effects. Important to explain these to your patients so that they're not coming back to you in 2 weeks complaining about the options, that they know that this is what's coming and hopefully they'll prepare for it. Some of the reasons to use implantable contraception is its long duration of action. So the thing that we're trying to get here in Canada is called Implanon. It lasts for 3 years. Okay, so that's a really nice amount of time in terms of spacing pregnancies. It can come out sooner, but it's got a nice long duration for patients who don't want to have to think about it for a while. It's not patient dependent. It's in your arm, and you don't really have to do anything. You don't have to change it. You don't have to do anything really for those 3 years. It gives you a continuous, after an initial, I've got sort of slides showing how it changes in your body for the first little bit, but after about 3 to 6 months, it's stable in terms of its hormone levels. It doesn't have the first pass effect from the GI absorption, hepatic metabolism, so it should be better in patients where they're maybe not absorbing things as well. And it has high bioavailability. It's the drug that's used is etonogestrel, which is the progestin that's found in Orthocept and in NuvaRing, but without the estrogen. So why is it among the effective? It's one of the most effective and safest forms of contraceptive that exists. The issue is it doesn't contain estrogen, so it doesn't have those increased risks of DVT compared to estrogen-containing options. Why else would you want this is, you'll notice when we looked back, especially in the older age groups, a lot of women rely on sterilization, although those numbers are quite decreasing since the last assessment. There used to be a lot more vasectomies, and it seems like there's maybe 8% for the couples now. Whereas it used to be more like 12 or 14. So they're not relying on sterilization as much. And especially for our younger population, 20% regret sterilization when it's less than 30. And if you've got someone in sort of those 21 to 25 age group, it could be as high as 50%, depending on your age group. So again, I'm saying this over and over again. The no daily motivation is a big thing out there. So this is just to show you some of the implants that we had. So if you're old enough, you will remember the 6-rod Norplant, or you've been practicing long enough, the 6-rod Norplant that was available. I believe it went off the market around 99, 2000, somewhere in that range. The 2-rod Jadel, which I've seen when I was in the States in study mode, but I haven't actually seen it being used in any of my patients. And then the 1-rod Implanon, and it's interesting, I am seeing patients now who have had it inserted in other countries and are coming here because they've run out for 3 months, and they're quite disappointed that they can't get another one when it's done. So far the satisfaction for the ones that I've seen have been quite good. The features, it's highly effective, not motivation dependent. It can be used during lactation. It's virtually invisible. There was a mention, if you go into one of those places that lights up things, like a Bolorama type thing that has the, then they may actually light up a little bit on your arm. So you may want to wear a long sleeve shirt if you go somewhere like that. But, and then rapidly reversible. So as soon as you take it out, you can get pregnant again very quickly. It's not like the Depo-Provera where it can take up to 9 months to get back to a regular cycle. Stable hormone levels and no estrogen, again, safe. So here's the limitations. Here's the issues that you're going to have to talk to your patients about, is it can cause irregular bleeding. So there's no perfect method out there, and this is the big negative that's going to be out there with the implant on. It requires a clinician visit for insertion and removal, and I know this might sound bad, but sometimes some of your patients who really need a birth control method, once you've got that insertion in, the fact that they don't show up and they keep rebooking for 6 or 12 months can sometimes be a good thing. They're not getting pregnant and they're using a good method that shouldn't be harmful to them during that time. It's more of a nuisance issue, but you've got it in. Another limitation in this situation, it doesn't protect against STDs, so you should still be encouraging condom use for the STD reduction. So this sort of shows you what the package looks like. It may be different in Canada, but it's basically the little device below is the inserter. So it comes with the actual inserter. You just put some local anesthetic in, you slide it in, and you basically just push it in to leave the implant behind. As I said, etonogestrel, the other one is just a membrane to allow you to, for the hormone to travel out of it. But the etonogestrel is the actual hormone that's being used. So 5 years, and then you can always remove and insert at the same time if you wanted to continue protection, reversible at any time. You take it out within a year, whatever you want, and her cycles will return to whatever they were before. So some of the pharmacology, so it's under the skin. The metabolism is this CYP3A4, so it's not some of the ones you've heard of in other ones, but I've got some slides showing what might interfere. So there is an issue, again, with the anti-epileptic drugs and the drugs that you use for tuberculosis in this medication, just as it would be for things like progestin-only pills and that sort of thing. So you would have to, if they are on some medications, it would be handy to have a chart around to make sure that it wouldn't affect their ability to use this method. So it works mainly by suppressing ovulation. It increases the thickness of the cervical mucus, and it can alter the endometrium so that the lining of the uterus is made thinner. So this is the slide I was showing you about the pharmacokinetics. So when you first insert it, there is a little bit of a peak, but by about 6 months, you're getting back to your steady state of what is normal. So ideally, when you have patients who are unhappy with how they're feeling initially, if you can encourage them to get past that 6-month mark so that they know what the true final outcome will be in terms of their cycles, in terms of the hormones and how they make them feel. So rapid return to ovulation, it's always a concern is if I want to take this out, how quick before I can get pregnant. The majority will ovulate within 3 weeks of removing this, and 94% by 3 months. So as I said, it leaves, because it's in a membrane and that whole thing leaves, your return to normal is very quick. So then the other question you have is how well does it work? And so these are specific studies. So you know that these types of studies have people that are very motivated. So they're the perfect users, not your typical users. But among all the cycles, very low pregnancy rates. So the real life experiences, some of the things that happen is they didn't really test for pregnancy, or a pregnancy was kind of just coming down the line just as it was happening. So it wasn't so much that it failed, but that there was maybe they had a negative pregnancy test, but they had unprotected sex within the last 2 weeks, and so it was just too soon for it to actually be effective. So that's how you get sort of your 1%. And then the other one is, of course, you thought you put it in, but it kind of fell out somewhere, and it never was actually in your arm in the first place. So just some very typical things where there's got to be ways for you to check to make sure that when you do insert it, it really is in there, and that it's you're not just feeling the local anesthetic or something like that. So those are the main issues with failure rates. Once it's in and you've got that time period where you haven't already ovulated, it's extremely effective in terms of a birth control method. And I hope that that's what they will promote in the future. If you can tolerate the side effects, if you know that it's just that effective, because that's what most women want. There's an issue in terms of body weight. So in Ever contraceptive patches, they talk about if you're over 190 pounds, should be considering additional birth control method like adding condoms or using a different method altogether. In the majority of the studies that they have on file, patients were not over 190 pounds. So you don't have the numbers to say when you've got patients over 190 pounds how efficacious it is. I don't think that it's saying you can't use it. It's just saying we don't know. We don't have a lot of studies on its effectiveness beyond that. Be alert to the possibility of an ectopic pregnancy. Sometimes progestin-only methods, one of the ways that they work is by sort of impairing the movement of the fallopian tube, and so there seems to be, if women do become pregnant, maybe an increased risk of an ectopic pregnancy. But we tell the women the same with IUDs. About 20% of pregnancies with IUDs can be ectopic. So if you become pregnant, see a physician or a healthcare provider right away to make sure that it's in the correct location. So the clinical expectations that you should have for your patients is that it doesn't make them anemic. Even though they're having unpredictable bleeding and spotting, their hemoglobin stays stable. So it's a lot like your Depo-Provera. It's nuisance bleeding. It's not dangerous bleeding. However, the difference here with Depo-Provera is there's no reduction in bone mineral density. So this is really exciting as another option for some of our younger patients where they want a really good method, and they've really been sticking to Depo-Provera because they're not good pill takers. But this one doesn't affect their bone density in the same manner. So it's a really good option, a new option for some of our teenagers. No increased risk of DVT. Again, the rarity of DVT makes it so difficult to say if there's a slightly increased risk, but because it's a progestin-only method, it's felt that it's safe for women who've had a previous DVT where they can't use estrogen methods. Little pain at the insertion site. It's a very small incision that you made, like just a few millimeters. Again, the changes in bleeding pattern, and you've really got to watch for those drug-to-drug interactions. So the main things that someone might go on without a physician's prescription or a nurse practitioner's prescription or a healthcare provider is St. John's wort. That's probably the only one you really need to warn them about. And that's the same with their pills. That's the same with a lot of the other birth control methods. It's one that seems to rev up your converting enzymes that would break down this product. There's associated non-contraceptive benefits. So your acne may decrease. You can't guarantee it, even though there's no estrogen to help increase sex hormone binding globulin and soak up the excess testosterone. The etonogestrel still seems to improve acne in most women. And another nice side effect here is dysmenorrhea can improve. So, you've got patients maybe who aren't good candidates for estrogen-containing birth control methods or don't want to take a pill or aren't good pill takers, that this actually can make their periods more comfortable. Because there is a good amount of progestin in there, there may be some minor weight changes and mild side effects like breast pain or headache. And I've got some slides that sort of show more specifics. So 61% had improvement in their acne, 32% had no change, and 8% it worsened. So you can encourage them that while we can't guarantee that it'll improve their acne, this method does seem to help. And again, that might help with your teenagers when it's got bonus side effects or bonus additional non-contraceptive benefits. Sometimes that can encourage the patient. Sometimes they go on these methods not for the contraceptive benefits, but for the non-contraceptive benefits. And then the dysmenorrhea. So 81% had improved or resolved dysmenorrhea. So this is big, again, for your teenagers. If they can put up with the unpredictable bleeding and spotting, it may help them with a lot of the other non-contraceptive benefits. So this is the big negative that I was mentioning. Regularly irregular cycles, okay, real pain. And I wish this wasn't here, but that's what we've got. So frequent irregular bleeding is a possibility, heavy menstrual flow is a possibility, prolonged bleeding, no period at all, spotting, and unpredictability. Again, by about 3 to 6 months, you'll get a sense of what your norm will be. So ideally, I'd want them to hold out for those 6 months and encourage them right from the start to wait for the 6 months before they give up on it. But it needs to be part of their counseling, and if that person is not accepting of that method, then we have to look at other options. So this sort of shows you, I hope the colors are good enough to sort of figure out, but so the first one is infrequent bleeding is your most common. Amenorrhea, which to me isn't so bad, and again, so the longer you go, you probably get about a 10 to 15% amenorrhea rate, which to me, again, that's bonus. If you don't have periods and you've advertised it as you've won the lottery if you're one of those 15%. And then prolonged bleeding does improve with time. So if you can get them past that sort of 6 months, those things should improve. And then again, the frequent bleeding should improve as well. But the infrequent bleeding, you'll see even after 6 to 12 months, you're still looking at about maybe 30% to 40%. So that's what they have to be aware of and accepting of. The nice thing is they looked at mean hemoglobin, and even though you're bleeding, you don't become anemic from it. So that's good to keep in mind for the patients who do have menorrhagia. This may be also something we consider for our patients that don't want IUDs but have menorrhagia. We've got another option down the road for these patients. So here's the big list, okay? So don't be too scared at it. I tend to look more, so the inducers are the ones that are going to make it not effective. Okay, and the inhibitors are the ones where you're going to increase their levels. But by having this device, you're going to increase their levels of these medications. So just kind of keep it in mind. Maybe have it up on the fridge or somewhere in the office, so that if they are on those medications, you'll know if there's a problem. But it's really the inducers where you probably wouldn't put it in the first place. Because, for example, with rifampin or the topiramate, and they have over a certain amount per day, you may not have effective levels to prevent to cause contraception. It may not prevent ovulation if you have those inhibitors. They rev up your system and you basically metabolize it too quickly, so it doesn't stay in your system enough to prevent ovulation and be an effective contraceptor. And you see they're mainly the ones that you have out there that are for TB, the St. John's wort that I mentioned earlier, and your seizure medications. Okay. So the weight gain, so mean weight change less than 4 pounds. So at year 1, about 2.8 pounds. At year 2, 3.7. So it's not as bad as Depo-Provera generally is sort of how I look at it, but there is still a weight issue. I think it would be helpful. I don't think in these ones that they're comparing them to placebo. I think pretty much everybody gains weight, especially when you get over 40. So you have to keep in mind how much of that is from your birth control and how much would be a placebo effect. Because if you'll see a slide that comes up a little bit later that compares copper IUDs and Mirenas, and to me, copper IUDs should not be increasing your weight, and they were gaining weight too. So I think everybody gains weight. You have to take this with a grain of salt. So safety. So your main insertion site symptom would be some pain where you put it in. A bit of redness, a bit of swelling, a bit of like a blood collection is a possibility, and expulsion was 0. So if you put it in correctly and you close it off, it's not that common that they fall out. You just got to make sure it actually was released when you put it in. So then the adverse effects, so bleeding irregularity is 11%. But if you notice, pretty much everything else is less than 3% in terms of emotional lability, weight increase, headache, acne, depression. So most of them are not stopping the method because of how it makes them feel or the mood. But there's a little 2 here for emotional lability. 6.1% had emotional lability that led to discontinuation. So I don't know what Canadians are going to be like. They'll probably be somewhere in the middle. So most, I wouldn't not start it because of that issue. But if they come complaining of that, I would probably try to at least get them past that first 6 months to see how they feel on it when it's more steady state. And then at that point, you'd have to reassess with them to see if this is something you need to remove to see if that's making a difference. So bone mineral density, if anything, improves in some areas. So this is big compared to our teenage. Like for our teenagers, I can see this being a big issue for our teen clinics. and a really important option for the future where women are concerned about bone density of teenagers, and we've been giving them Depo because we really don't have another option. This is going to give us another, and we maybe don't want to put an IUD in because they've had an STI every time we checked. Then this is going to be another option we can include. But I don't want you to think this is just for your teenagers. It's an issue for a lot of those patients that haven't had a good option up to now or a good alternative up to now. So no increased risk of deep venous thrombosis. So they had 4,000 women years of exposure. So because the rates of DVT are so low, we can't say for sure that there's absolutely no increased risk. But certainly I would feel much more confident giving this than the estrogen-containing birth control method. Any progestin-only method can set you up with ovarian cysts. So that's the same issue with Mirena. And they just disappear on their own. They don't usually require treatment, but if someone's complaining of some pain on one side or the other and you do an ultrasound and you see this, the majority of times when you follow them, they will disappear on their own. But it can be an issue if they're having a lot of discomfort related. So a little bit more about selection, timing, counseling. So no method is perfect. When they look at how many actually continue, so 75% 1 year is pretty good. 2 years, 59%, 3 years, 47%. But maybe some of those wanted to become pregnant. It's hard to know if it's side effects or if it's other reasons that are having them continue. But this is a lot better than a lot of methods that are out there. So bleeding irregularity, here's your big reason. Again, you'll hear me say this a million times. So the pregnancy planning was 15%. So it wasn't a huge proportion or contraceptive. So maybe 20%, about 1 in 5 had legitimate reasons for removing it in terms of they wanted to attain a pregnancy, and that's a positive thing for them, as opposed to a side effect or a complication of using the method. So pretty much gone over this. So contraindications, known or expected pregnancy, they have our past history of thrombosis or thromboembolic. It tends to be more the current history. They have to include the past history, but it's still considered to be safe in someone with a previous DVT as a contraceptive option in the WHO guidelines. And then hepatic tumor or active liver disease. So that'd be something to look into. I think pretty much any adenoma, you're having to stay away from progestin-only methods or any kind of method. Active liver disease, again, I would refer to the WHO and now the U.S. medical eligibility criteria to see specifically, because some of the chronic Hep C and that kind of stuff, as long as their liver enzymes are stable, they could still tolerate this. Undiagnosed abnormal genital bleeding, so you got to figure out what's going on before you put this in. Cancers of the breast or a personal history of breast cancer, not a family history of breast cancer. And then hypersensitivity, if you had some reaction to etonogestrel or the rate-limiting little plastic thing that's being used, obviously you can't use this. Best timing is within 5 days of initiation of menses to make sure that it starts working before you ovulate. Or if you are switching from a combined OC, within 7 days of the last active tablet. From the progestin-only method, if you're progestin-only pill, you just keep taking your progestin-only pill until you put this thing in. Same day as you remove an IUD or an old implant, and then on the due date for the next contraceptive injection. So like Depo-Provera, within that time period before the next one's due is fine. So after abortion, the recommendations from the company are within 5 days of a first trimester abortion, within 6 weeks of a second trimester abortion. Again, for implants, they say you can put them in right away. So this is another example where we could potentially insert this. We do our procedure, and the very same day we insert this before they go home so that they are protected right away. After childbirth, there's a little bit more controversy in terms of breastfeeding issues. We'll have to look into that before we bring it out there. So if you have someone who's not breastfeeding, you could put it in right away, and ideally within 6 weeks. You just want to make sure they don't ovulate, since many of them can ovulate within 3 weeks, especially if they're not breastfeeding. Ideally, I can see us putting them in before they go home. So considered safe with lactation after 6 weeks. So as long as they're not at risk for pregnancy when they come in for their 6-week postpartum visit, that's a good time to put it in. And so low concentrations are present in the milk with no associated adverse effects. So they say less than 1 minute for insertion, less than 3 minutes for removal. Because I haven't been practicing, I would probably go higher, but I'm sure with time you'll get faster. Okay, so It's practically invisible. It is subdermal, so if you've got a really skinny person, potentially you could see it if they kind of made their arm go like this. But it's usually sort of just in this area right here. And not painful to insert. You put some local anesthetic in, it's not that much. Infection rates are rare. No long-term health problems, so less issues because the estrogen isn't being used. No health problems in the children conceived after use. It drops down very quickly to levels you can't detect. And decrease in libido rarely occurs. Again, a progestin-only method, lower doses than some of the other hormones that you have out there. Very effective. So, if you put it in correctly, almost no pregnancies will occur as long as it hasn't, mistakenly been put in at the wrong time. You follow the rules in terms of insertion, and you didn't drop it on the floor when you thought you put it in. Then you should be pretty good. And as long as they didn't take medications afterwards, they didn't then go on seizure medications. So you have to be aware of that as well. And low serum hormone levels, and it reverses rapidly. So that's a really nice feature for women who maybe are a little bit older and want to retain a really good method, but then want to get pregnant right away as soon as they take it out. So in conclusion, I'm really excited when and if this, well, I'm sure it shouldn't be an if, it should be a when. When this comes out, I think this will really change my clinic and hopefully many of your clinics as well, as something that we can offer to many patients. And most reproductive age women are candidates. So that's my implant part. Okay, so now I'm going to go quickly to IUDs. Do you mind if I, yeah? Oh, yeah, we can do it at the end. Yeah, no problem. Yeah, I can do it after. Yeah, okay. So this is just quickly about IUDs because I don't want you to think, oh, implants, no more IUDs. I really think IUDs in the intrauterine systems. I mean, we do a lot of those. Are also really good options. It's just nice to have something else where women don't want something inserted inside their uterus. So this just kind of goes over the history of what we have, and I wanted to show you some quick pictures of what's available in Canada, because back in 2008, we got a new one. And the main reason I like the new one is just cheaper. Okay, so as new one comes out, hopefully it will reduce the prices so that we'll have more options for patients that are less expensive. So basically the ones that we have that we're currently using are Nova-T, Mirena, Flexi-Ts of the different types, and the Liberty. And apologize for the accent, it's going in the wrong direction. So this sort of shows you what's out there right now in terms of slides. So we've got there, basically I say they're all good for 5 years. The Nova-T was approved for 30 months, but it's been studied for 5 years. So whenever someone comes in at 3 years and says, I need my IUD removed, I tell them it's good for 5 years, go home and I'll see you in 2 years unless you need it out for other reasons. So you've got your Flexi-T, and I'll show you some pictures there. And then the Liberties, there's a standard and a short. The specifically one for the Mirena, important to know that you can't put that in for emergency contraception. I'll mention that again this afternoon. So ideally, a Mirena is inserted in the first 7 days of your period or any time in the cycle as long as she's not been at risk for had unprotected sex in the cycle. And again, reversible, continuation rates are high, extremely effective. This one lasts for 5 years. Okay. With the Mirena, you've got the reduction in menstrual loss, whereas your copper IUD options tend to increase your menstrual loss. Early spotting is common, big part of your counseling. Just like with the implants, expect for the first 3 to 6 months that you're going to have some issues. And the Mirena, I also promote it because it's more efficacious at preventing pregnancy. So I just want to show you the Nova-T and the Mirena are made by the same people. And just sort of show you, so they look pretty much identical, except that the Mirena has the levonorgestrel where the copper is on the other one. And as a result, it's a little bit skinnier, the Nova-T, in terms of inserting it through the opening. The Flexi-T length is the only one that's a little bit shorter width-wise. Okay, so the Flexi-T 300 is specifically made for women who are nulliparous, and sometimes it's also easier to get that one in women who have only had a C-section. And so its length is 28 millimeters, but its width is 23 millimeters. Whereas the Flexi-T is width of 28 millimeters. So it's, whereas the other one back here is 32 millimeters. That's length, sorry. but it's 32 by 32. The width is a little bit less. And one of the advantages with the Flexi-T that we don't have in any of the other copper IUDs or even the Mirena right now is if you have concerns about a patient's uterus, the width being too small, the Flexi-T 300 may be a better option for those patients because the studies have suggested that the types of IUDs that we use may actually be too wide for the nulliparous patient. And that's based on ultrasound studies, not based on anything that we can really measure very easily. So I apologize, I can't get a good picture of the Liberty one, but again, 32 millimeters wide, so similar to the Nova T again. So it's pretty much like a Nova T, but cheaper, okay? And sorry, that one has a short, which is 28 millimeters long, whereas the other one is 35 millimeters long. So yeah, they're all 32 width. So as I said, the Flexi-T 300 is the only thing that offers you an opportunity for a different width. Okay, they're only dealing with length and all the other ones. So this just sort of shows how Mirena works. So it works a little bit differently than some of the other methods in that it's more working by thickening cervical mucus. There may be a little bit of ovulation inhibition, but not necessarily. Endometrium suppressed, where you may not get that with copper options. And then it certainly, there is a weak foreign body reaction, which is the main reaction that you get with your copper ones. Efficacy, so this is your big thing, I describe it as less than 1% over 5 years is the easy way that I remember pregnancy rates with Mirena. And this shows the reason why, especially in younger women, you want to promote the Mirenas. The Nova T has different pregnancy rates across different ages. So the younger you are, the more fertile you are, the less likely the Nova T is to work. Okay, so if you're getting up to 36. May not be as much of a difference between the two, but when you're less than 25, there is a big difference in how well Mirena works compared to a copper IUD. And again, the Nova T is the only one that's been studied, so we can't compare it to the other ones that are out there on our market, only to the Nova T. Some of the other ones have higher amounts of copper, so potentially they may be more effective, but we just don't have the studies. There's the newer ones, the Flexi-T and the Liberty, just don't have as much research and articles on them in terms of efficacy as the Nova T. Okay. So when we compare it to sterilization, so the Nova T, I say about 1% a year for the Nova T for risk of pregnancy compared to less than 1% over 5 years for the Mirena. If you look at all sterilizations, the 5-year cumulative failure rate is 1.3%. Again, when you've got your young patients, when you've got someone who's under 27, your risk with a Hulka, if we used a Hulka clip, is 5% over 10 years. So it's actually more effective to use a Mirena compared to our Hulka clips based on the CREST data that we have. But it wasn't a randomized study. It's just sort of general numbers out there. So hard to exactly compare. A postpartum salpingectomy tends to give you your highest rates of efficacy for compared to an interval sterilization where we do it 6 weeks later and we do a laparoscopy. So it is comparable if you do a postpartum salpingectomy, but those are very difficult for us to arrange. This just shows you levonorgestrel. So with the implant here, they're comparing Norplant when we had that available. So we don't have the exact numbers, but what it's showing is Mirena had even less than the Norplant implant that we had before in terms of the amount of progestin that's in your system when you take a pill at the same time every day. So you're getting much more hormone with your combined OCs. So that's sometimes a counseling point that I use when they talk about not wanting very much hormone, saying that this is the lowest hormone that you can get out there on the market with the Mirena. So the early spotting, it takes up to, and I say 3 to 6 months for full effect on the endometrium. So my counseling point there is the Manitoba winter, okay? Instead of, if you're in BC, they talk about getting over the mountain and then you get into the valley and beautiful weather, blah, blah, blah. Here you have to get over a Manitoba winter of 3 to 6 months before you have a nice menstrual cycle, maybe even no periods at all, but a reduction in your bleeding, whereas initially you have to get through that, how I often describe it is dribbling bubbling. It's a very visual kind of sound, but it's not heavy bleeding, but it's unpredictable bleeding. It's nuisance bleeding, and it's kind of annoying. You got to get through that Manitoba winter, and then you got the spring and some summer, but then it stays that way. Okay. So this sort of shows the number of bleeding days. Unfortunately, it doesn't have the things along the top, but just showing it could be as many as every other day in your first of bleeding in your first month or two. Okay, so this sort of shows you in the first couple months. I say every other day, like 18 days a month is not unusual to have some bleeding or spotting. Often those ones that are breastfeeding, they have less, or if they've just come off depo, they seem to do better. But then eventually, by the time you get to the 3 to 6 month mark, it'll settle out, and it should be lighter. Your periods should be lighter than they were before you started. 20%, so 1 in 5 hit the lottery, no bleeding at all after 12 months. So you have to promote that as a big plus. Otherwise, you have patients who come back and want it out because they're not having periods and it worries them. And then this is in terms of treatment of heavy bleeding. So by even 3, then 6, then 12, using it as a treatment for menorrhagia. It's a bonus. So when I have patients that come to me and want their tubes tied, I make sure they don't have menorrhagia at the same time, because then I talk about how it causes 2 good effects, and how if they were on the pill and I sterilize them and now they go off the pill, they're probably going to end up having a Mirena or a hysterectomy somewhere along the way. Because they aren't using anything to treat their heavy menstrual periods, whereas the Mirena does 2 at once. Okay, so I've hopefully burrowed this into you. And then treatment of heavy menstrual bleeding. So endometrial protection with HRT, I don't see that as much, but I like to discuss it in women. Say that they're 45 when they put it in, and say that they start getting hot flashes and maybe they need estrogen replacement at 50, okay? Then I just keep in that Mirena, because potentially it could have at least 7 years of protection. It has more than even the 5 years that are there, so that they don't need to use Prometrium or any of the other Provera to suppress the endometrial lining when they're using estrogen replacement. So then prophylactic antibiotics, there's been no study that suggests that it affects the risk. So you don't need to give them prophylactic antibiotics before you put in the IUD for the average patient. This just shows that, if anything, Mirena may be protective compared to a Nova-T for PID. And then when you look at PID incidence, it's in those first 30 days after you insert an IUD that your infection risk is higher, and after that it's sort of returns to a sort of more normal level. So basically what I counsel is if you're well past 30 days, just if you have a new partner in the future, you got to make sure he's tested to make sure he doesn't have an STI. Use condoms until you know what's going on there, but otherwise it shouldn't have a significant increase in your risk. Expulsions is an issue with Mirena, 6%. What I've read in the literature is about, if it happens once, there's about a 30% chance it's going to happen again. So there is a concern if it's happened once that it'll happen again. And usually they occur within the first 6 months, but they can occur at any time, and that's why I like to bring them back at 6 months to make sure that we see the strings, and ideally have them check for the strings each month after their period. That's their only sort of check thing. Most patients I find aren't doing that, but we have had a few pregnancies where it's fallen out and they haven't realized it, and we've known that because they continued their pregnancy or they had a termination, and then we did an X-ray of their entire abdomen and pelvis to make sure that it wasn't anywhere in their abdomen or pelvis, and if it's not there, then it must have fallen out. And then the perforation's about 1 in 1,000. So most of the time, if you're not seeing the strings, either the strings have pulled up or it's fallen out, as opposed to perforation, but still worthwhile to check for that when this comes up. So IUC, the intrauterine contraception for women with medical conditions. So the nice thing is, just like the Implanon, there's a lot of patients that maybe weren't good pill candidates that you can use Mirena on. So obesity, there's not that issue with over 190 pounds with Mirena. The smokers, especially over 35, if they have risk factors for coronary artery disease, they have hypertension, DVT, PE in the past, mutations that make them at increased risk. Though these are all okay. Epilepsy isn't as much of an issue if they're on those medications that affect it. Depressive disorders, migraine, because it's a very, very low dose of hormones that you're getting. So who is inappropriate? So even though it's a really low level of hormones, breast cancer is still an issue, so that not a family history of breast cancer, but a personal history of breast cancer. And even then there's some controversy, if they've been good for 5 years and they don't have, the alternative is pregnancy, it's something that some will consider, but it's not first line. So basically, your other things are infection, usually within the last 3 months. So past history of PID doesn't exclude you from it, but a recent history of any kind of cervicitis that hasn't been treated, or of PID or a postpartum endometritis and that kind of stuff, you want to wait at least 3 months for the infection to be gone before you put one in. So we do put IUDs in nullips. I'm not successful putting them in everybody, but I've had some good success with nulliparous patients. But I do warn them if they have to pay for it out of pocket, especially then sometimes it doesn't fit and they have problems with pain afterwards. And I don't know who's going to have the problems with pain. I tried to do a couple ultrasounds, but I found it not very fruitful. You sent them and then they said, oh, bring her back. We didn't really look. Or, so it's just sort of a waste of time, and I'm not really sure. I think it's still something I might offer occasionally, but it hasn't been part of my standard for nullips. I have lots of nullips that do well, and I'll have to sort of keep track of them to see what sort of percentage has issue. But every once in a while I have patients that might have more pain. Definitely there's studies that suggest more pain with insertion with nulliparous patients putting it in, and there may be some that go on to continue have a bit more pain, but it's not a contraindication. I think it's still worth a try, and we have lots of happy nullips that do well. Previous PID, again, as long as it's gone and they've been negative for 3 months, they've not had an infection or problems, we can put it in. Previous ectopic pregnancy is not a contraindication. Previous C-section, as long as you can get it in easily. Previous VTE, and adolescence. So it's been mentioned now specifically in adolescent journals that it's not an absolute contraindication. You can use it in adolescents. They just need to be appropriately selected and counseled, and you want to follow them up closely. So if you develop new breakthrough bleeding and spotting in an adolescent, definitely check for GC chlamydia to make sure they haven't developed an infection, and then you can treat that infection. You don't have to take out the IUD if they have it, as long as they don't have signs and symptoms of PID. I tend to do 2 visits when possible, but if I've been referred and they've already done swabs, or if they live far out of town and they're willing to just say, well, you're at low risk, we'll just insert it and we'll do your swabs and we'll call you if there's a problem. I've done that a lot as well, but ideally they have their IUDs with them when they do that. And then efficacy and safety, we just review that. We review the return to fertility, the side effects and the health benefits, changes in bleeding patterns, and then the follow-up. And again, sometimes especially if they live out of town, I have them follow up with their own healthcare provider in 6 weeks just to make sure that they don't have any signs of PID, and that I cut the strings, usually do about 2 centimeters, to make sure that they still see the strings at 2 centimeters. So it's a very fast visit the next time, but I think it's just good to make sure that any problems have been addressed. You reassure them about the bleeding patterns, that they haven't had any signs of infection, reassure you that they haven't fallen out. It works very well. I said less than 1% over 5 years. This just talks about return to fertility for the Mirena and the Novartis. So the cumulative pregnancy rate's very high for both methods. You remove it and they can get pregnant that month. Some side effects. So most side effects are less than 5%. Breast tenderness, nausea, that kind of thing. This shows the weight gain of after 5 years. So it's 2.5 kilograms in the Novartis, people with just copper. So to me, that's just placebo versus the Mirena. So women just gain weight. It's an unfortunate fact of life, and so it shouldn't be because of the Mirena that they're gaining the weight. And then the absence of bleeding, to reassure them that it's not a sign of anything wrong. You especially some patients who believe that they have to have a menstrual period every month to be cleansed, important that they understand that right from the beginning. Ideally, I like to have an up-to-date pap smear based on the Manitoba guidelines and screen for tests. So I screen for GC chlamydia routinely. Some don't feel that this is necessary, but I prefer to do that. And then I check for BV and trick if there's a discharge. If there's not a discharge, I don't check for those. And then it's standard now in the WHA to do a urine pregnancy test on the day of insertion. So usually it's the 6-week follow-up that I end up doing so that they've had a period, especially the ones with copper IUDs. You want to make sure that you tell them to take something for cramps, and that how did they do? Did they do okay with the cramps with that last period? And then they just return to their own healthcare provider with annual exams as routine or the Q2-year pap smears, whatever their healthcare provider does. So dispelling myths, IUD increased the risk of infertility. Specific studies, this was copper IUD use, showed that it wasn't an IUD that increased your risk of infertility, but it was the presence of chlamydia antibodies. So it's the presence of an infection that they're blaming the IUD for, not for null-gravid women that increases their risk, not an actual IUD use. They prevent implantation. Most of the things we feel are acting before implantation occurs. But it's one of those issues. I think pretty much any birth control method out there, you can't guarantee that it's not affecting it at an implantation level. It's definitely not harming a pregnancy once it's actually implanted for most of the methods. I'll go over that a little bit more maybe with EC. Best time to insert Mirena. So timing is different for insertion for the copper IUD and the Mirena. The copper, because of the EC that I'll talk a little bit more after this, is much more flexible, whereas the Mirena, you have to insert in the first 7 days of your period. So copper, you can do 4 to 6 weeks postpartum, or if it's a C-section, I like to wait a little bit longer, wait 12 weeks to put it in to let that scar heal. And you can put in at the time of a termination of pregnancy. With the Mirena, they can do 4 to 6 weeks postpartum, time of abortion, and safe for lactating mothers, again, consider 12 weeks. So there's not too much difference there as long as there's not a risk for pregnancy when we're putting it in. So again, Mirena not used for emergency contraception, copper IUDs, emergency contraception, so up to 5. So some will say 5 to 7 days after unprotected intercourse. And any time if no unprotected intercourse 5 to 14 days ago, because that time in before may be too soon to have a positive pregnancy test. Day 11 to 17 of the cycle seems to be a good time to insert it, but I haven't really been very strict with that because I just try to get them in, I try to reduce the number of visits. I think convenience is a big issue for these patients. They usually come in and want everything done once. So I mentioned earlier, if you have a IUD in place, so sometimes, especially if I'm doing a pregnancy termination, I'm inserting an IUD right afterwards, I'll have taken the swabs, I put in my IUD, and then very rarely I'll get a positive, usually chlamydia, infection afterwards that was asymptomatic. She didn't know about it. So then what I've been doing is we give a gram of azithromycin to everyone who gets a termination of pregnancy anyway, so they're automatically treated. So we're good. But if I have somebody in another circumstance where, again, they live out of town or something, I just put it in and I find a positive, you want to make sure they don't have any signs and symptoms of PID, but you just treat them right at that time. Ideally, bring them back just to make sure that they don't develop any signs or symptoms of PID. And if they're good and their partner's been treated and they're not at risk for getting this infection back again, they can keep their IUD in. And that's it for the first one. So a lot of slides. The second one is much shorter. I kind of made this a lot longer, and hopefully you'll get a bit of a break in between.
So just stay tuned. Maybe we'll just go to questions. I don't know if any of the rural sites have questions first. We'll start there, and then we'll go to Winnipeg here. Here's your chance, guys. Do they just press the button and speak? Well, maybe while they're getting that organized, we'll start with the question here in Winnipeg. Go ahead.
I just wanted to know how you get the implant on out.
Out, okay. So what I was trained in for the Norplant was something called a pop-out method of contraception, and that's a much simpler method. So if you basically just put a little bit of freezing underneath where the end of the implant was, you get a scalpel and you just cut like a very small incision, sort of 3 to 4 millimeters, again, where it was. And then you basically you push it towards where your opening is, and you basically do like a crosshatch mark. It sort of just slides out through the little hole. And so once it's slid out enough that you're not going to cut the skin, you're just cutting on the implant, you do like a crosshatch mark over the edge of the implant, and it just pops out. The other thing, you can do something like a Halstead or a mosquito forceps, where you just kind of, after you put the freezing in, I made a little incision and sort of pushed it out a little bit. You grasp it with something, and then you can use like a sponge or something like that, just to kind of tease off those. It's just in a little capsule, so you sort of have to tease off the capsule. So yeah, it can be quite quick as long as it's coming towards you. So the issue with some of the other Norplants, some of the reasons there were problems is if you didn't insert them properly, you might put it into near a vein, or you might, near an artery, or it might migrate and be somewhere completely in the muscle, and those are going to take a lot longer. But when you've put it in correctly, it should be very simple to remove.
Okay. Thank you. Have we got any other questions? I'll maybe check with the rural sites again. Must have answered all their questions during the presentation. But
I hope so.
I'll give you guys another moment to think of some questions, because I see another one here in Winnipeg. Go ahead.
I'm just wondering if you know what the cost might be for this implant.
Again, I won't. I've heard. Okay, so if you think that the way that they were describing it is, if you thought that it would cost $350 for a Mirena for 5 years, they were going to try to cost it as like 3/5 of the cost of a Mirena, so that it would be an equivalent per year cost to the implant. That was the thinking a year or so ago, but I can't. I'm not the voice of the company. That's just what I know they were thinking.
So they're thinking not more, but
yeah, probably under 300, I would expect, is what they're aiming for. But wait till it comes out to know for sure. But that's definitely something they have to consider.
okay.
And I tried to call them to see and I didn't get anyone calling me back to see when they thought it might come out. So I don't have any additional information. I know that the dates that they had initially been thinking of have been postponed. So just because I even give you a date doesn't mean that's going to be the date anyway.
Right. Usually no callback means it's a work in progress.
It's a work we don't know. Yeah.
Okay. Any other questions? I think we have one more in here in Winnipeg, but I've been told that we absolutely want to give you a chance out there across Manitoba.
I actually have a few questions.
Okay. I'll try.
Okay, go ahead.
One question is, what's the difference with the Implanon from Norplant? Because there were huge issues with Norplant when it was pulled. I'm just curious as to what's different about it that they think it doesn't have the same effects.
So do you have any specific concerns from the Norplant that brought to mind for you?
I'm trying to remember. That was a long time ago. I just remember that it was quite drastic when they pulled it in terms of the risk for it. I should have looked it up.
Yeah. So just in terms of my memory, I just wanted to know if there was something specific that you were thinking of. But in terms of my memory, there were a number. Like implants have not been a big market share, and that's always an issue. Like say they were less than 1% of all the contraceptive methods out there. So they weren't making a whole lot of money on it. Number one. At least in the States, because Norplant is still available in other countries. And then there were too many lawsuits. And the lawsuits tended to be, you've got 6 implants, and they weren't necessarily training them properly to put them in. So that was a big thing they'll have to do differently, is make sure that that they really train them well, so that they're not going into arteries, they're not going deep into muscle, and the issues that come up with trying to remove them when they've been inserted in the wrong location. Okay. And then I think the thing that finally sort of killed them was there was a number of certain ones where they said they may not be efficacious enough. And that's when I remember they took them off the market completely. Mm-hmm. So I think it was like there were just too many things and they weren't making enough money on it. It was sort of my theory as to why. And too many, the U.S. is certainly a lawsuit driven, very, very high numbers of lawsuits that sort of made them say it's not worth it in this market anymore. We're not making money.
Okay. That actually led to one of my other questions, which was, is it looking like for insertion of it that we're looking at gynecologists or GPs being trained? Like, are they thinking about who's going to be trained?
I'm not 100% sure. When I look around the room of who was at that meeting that I went to maybe a year or so ago, I think that I think they're going to start with physicians, and I think they could still be family docs. I think they're going to start with physicians, but then I think that they would then expand it once they're comfortable, like once they've got enough providers or whatever. So I think they're going to start with physicians. Maybe the physicians will be trainers, and then I think it kind of goes to bigger and bigger numbers, and as the bigger numbers get out there. But I can't say for sure. I think that'd be a good question once it becomes available. I think that's part of what's taking forever for them is those types of questions. How are we going to train them? Who's going to be trained? What kind of what's the number of things you have to do before you're qualified, all that kind of stuff. So I think they're still working on that.
The reason I'm asking that is Mirena's been around for a long time, and I still continually hear that GPs don't put them in. My GP doesn't put this in. My GP doesn't put this in.
Yeah, so, and there's not an issue. I mean, we have a nurse practitioner that puts them in.
I know.
Yeah, exactly. So
it's just
it's an issue of comfort. It's an issue of, I guess, your patient population. Okay. It's not an issue of the person. Like it's just what people are. I don't know. And again, it's hard to know how to motivate. Ideally, the more people we can get that are well trained. I don't care who they are, if they're well trained and they have good success rates, and then great. It's the more people, the better.
Okay, so I'm just going to skip to Mirena's there for a second. Is there any guideline for people who have chronic bacterial vaginosis in terms of putting in your Mirenas or your IUDs? Like post-TA, we'll treat them because it can cause an infection in the uterus. Yeah. So I'm just wondering
The only guideline that I've seen is if you look in the STI guidelines for Canada, they talk about BV and they talk about treating it before inserting an IUD. But in terms of if you have an IUD already, then you should only treat for symptoms. I don't think you need to treat it for BV that's present. Like, you don't have to screen for it at that point. But if a woman says, I have symptomatic BV, then you treat her for the symptomatic BV, independent. But if you are going to insert an IUD, for sure. Otherwise, I would say only symptomatic, and then you can use their guidelines.
So no change to how you would treat the BV in an average person if they have a Mirena.
Correct. Yeah. Okay. Yeah. It's all based on the guidelines.
Okay, and sorry, I had a lot of questions. You said you could put in the Mirenas or the IUDs post-TA. Would you go up to second trimester TA, or would there be? Yeah,
that's actually that's been in the literature very, very recently. My personal thing is one of the things that I find is their uteruses are much bigger. So what some people actually do is like sponge sticks, and actually put sponge sticks in there to kind of leave it at the top of the uterus and bring it down. And that's not something I've really felt that comfortable with. So when I do it, I've still been using the inserter. Okay, and so then you get to a point where you can't measure anymore. It's beyond the markers of the size of it. And I have had some expulsions that have happened. They feel that there is an increased rate of expulsion. I don't have good numbers, so say it was 6%, it might be double, it might be 12%. So I still insert them as long as I'm not worried about bleeding. So if I've got someone who's bleeding quite a bit, because I have had patients who end up with hematometras, and then, heard about it, and then their IUD gets taken out because of a sort of complication. So they can't be bleeding too much, and then I have inserted them, but I warn them that they may fall out. So if I see them 6 weeks, I have ways I can get them other ones if it falls out within 6 weeks. And the reason to put them in a second trimester patient is there, as I said, there were more expulsions, but there were more women there were very few women coming back at 6 weeks or 2 weeks. Like, I make appointments for these patients that don't get them, and I would guess 70% of the time they don't show up. Even though I give them an appointment and say, come here on this day, I will put it in. So that's the reason that they're recommending it, is there's a higher success rate of continuation, despite the fact that some more fall out, and that they have a good contraceptive method long term by putting them in even in second trimester patients.
I think that strategy would also apply to postpartum, but that's another conversation.
Yeah, so postpartum, and they have done studies with that. It's a much higher, even higher than that postpartum. I think it's a third. fallout when they insert it immediately postpartum, and I've seen them do it at time of C-section. Like, I've heard of them doing it. It's just such a high rate that I think we're not as keen. And you have to kind of bring it in with them, and I'm just not sure how many would actually bring them in. You have to almost provide them for them when they come. You'd have to have a really coordinated effort with all physicians in that group, because there's so many people that are in the group on side. It'd be much harder to coordinate.
Okay, that's it. Thank you.
Sounds like a very good research question, cost analysis and social justice issues there with the postpartum. But
Yeah, and it has been studied. There are more studies. There are more.
we're not there yet.
Yeah.
Okay, in the interest of, thank you very much. Well, we have our next presentation. I'll give Dr. Pymar a chance to catch your breath, and we will have time for questions after, but now we're going to turn our attention to looking at some of the clinical issues in emergency contraception.
I thought you were doing another talking with me.
No, I am not. It's the Helen Pymar show.
This is much shorter. How are we doing for time?
Half an hour, and then
Oh, that's
about 20. Then we'll have about 20 minutes for questions. And
great.
wrap-up.
Okay, perfect. That's great. Okay, so again, this is another one where I thank the Association of Reproductive Health Professionals for some of the slides that are on here. And I've just given you the website as well, if they allow you to take slide sets for a number of different topics if you wanted to use these yourself for other patients, or patient information, and often in different languages as well, related to contraception. There's actually, I have right here something that was made by a quick reference guide for clinicians on choosing a birth control method that you can download. It's about this thick. If you also wanted to have that available in your offices. So what I want to talk about now is emergency contraception. And in the U.S., where they have a lot of these things, they also have things like mifepristone, RU486, and they have some other ones that are coming on the market that are like, like mifepristone, that are more effective than our Plan B, but unfortunately, I'm describing what's available in Canada on our things here, and again, there may be some better EC if Canada decides to adopt them in the future. So I wanted to talk about progestin-only emergency contraceptive regimens, identify the mechanism of action, and understand the link between EC and risk-taking behavior, because that's what a lot of people have used as an argument to justify not having EC available over the counter. Effectiveness of ECP, so it's not 100% effective. It's important that our patients know that. How to begin contraception after ECPs, and how to enhance the availability of EC. So this is a picture of the Plan B regimen. When I contacted a pharmacy and asked them about the generic, because I believe there is a generic available, they didn't say that they had the generic available. So generally when I was asking them sort of what it might cost, around $25 is sort of what I was giving. There may be some cheaper ones in cheaper locations. I think you can buy the generic for about $6, something around that level, but I'm not sure where you can get it from. So I think in most situations you're going to be looking at around $25 to get Plan B over the counter. Both pills are taken at the same time, so they now have that on the thing. They used to talk about taking one and then another one 12 hours later, but you can imagine you take one at 3 in the afternoon. You have to wake yourself up at 3 in the morning to take the second one, and the two pills at once work just as well and have the same side effects. So why would you do that? It doesn't make any sense at all. The other change in recommendations are that it works up to 120 hours after intercourse, but the sooner you take it, the better. So we used to say 72 hours, now we're saying 5 days. But still best to take it as soon as it happens, because it's going to be more efficacious. How might it work? It could inhibit ovulation. That's felt to be the main way that it works. It might thicken the cervical mucus if it can do it fast enough so that the sperm can't get through. It might affect the tubal transport of the egg or sperm. It might interfere with the fertilization or transport of embryo, or prevent implantation. And the true an abortion is supposed to be that you've affected it after it is implanted. So some people are concerned about, they want to try to prevent it before egg and sperm meet, which is, again, the main mechanism that they feel that it works. But there is always a possibility it can also affect uterine lining and affect implantation. So this is this is levonorgestrel. What you're getting in Plan B is levonorgestrel, but in a pretty good dose. So we've done some studies specifically looking at all of these things to see what causes it. So it can inhibit ovulation, but not always. It can immobilize sperm by altering uterine pH. There's some things that it can affect in the endometrium or shorten the luteal phase. Excuse me. So in animal evidence, there was no post-fertilization effect that it impairs fertility. I think they just are saying that they can't guarantee that that's the issue. However, they sort of mention that pretty much any birth control method that we're using may work by inhibiting implantation of a fertilized egg. So even though we think that the main way OCs work, implants, all those things is preventing ovulation or thickening cervical mucus so things can't get together, we can't guarantee that for any of our patients that for sure it may also work by preventing the implantation of a fertilized egg. Even contraceptive effect of breastfeeding. So it's just kind of going into all those things, that those are possibilities with all of these methods, but it should not affect one that's already implanted. Okay. And then Plan B's ability they're saying it can be fully accounted for, that don't involve. So there's a lot of issues in the literature. I think we just can't say, we can't guarantee that it's not a post-fertilization effect, but it should not be a once it's actually implanted, should not affect it. So the other thing and it's not as much of an issue here as it is in the States, where they still have some restrictions on over-the-counter use, but it may be sort of a counseling point in that if you counsel about ECPs and you give them on demand, or you actually give them in advance for later use, so they want to see whether or not it increases your risk-taking behavior. And unfortunately, so if you got it in advance, as opposed to having to go to the store and pick it up, you were more likely to use it. But unfortunately, that did not translate into less pregnancies. Okay, so it's a really unfortunate thing. I thought when ECP first came out that we were really going to make a big difference in terms of unplanned and unwanted pregnancies, but unfortunately, when they received them in advance, they weren't more likely to use them repeatedly. They weren't more likely to have unprotected sex, so it's not changing their behaviors. It's not, they're not changing to less effective contraception because they have this thing in advance. They're not using it less consistently, and they're not more likely to acquire an STI. When you gave it to them in advance and said keep it in your dresser drawer or whatever, they were more likely to take it sooner, which is good. And they used other methods of birth control equally well, but they were not less likely to become pregnant in the studies that were done. So why is that? It increases use, but it hasn't been shown. So among the women that were using it, even though they had it, they didn't use it, in a time where it would have been a good time for them to use it. 80% of pregnancies occurred in women who did not use ECPs in that cycle, so they may not recognize that there was a problem. They may not have known that the condom broke, or they may not have realized that it wasn't taken off properly or something like that. So I think it's effective at that one time if you knew, compared to someone who didn't use it, but unfortunately as a population it hasn't been shown to decrease the overall numbers. So this one, for those who received it in advance, they used it at least once. No effect on abortion rate was observed. The 78% of women who had the supply didn't use it when it would have been a good time to use it. So a lot of the women at risk weren't using it. So I'm not sure if it's counseling, like just explaining when do you use it, and they just weren't using it. But these were patients who were counseled in a study setting. So it makes it a little bit more difficult to know what to do here. In the past, we felt the USB regimen was actually created by a guy, and I don't know if he was in London. I trained in London, Ontario, and so I met Dr. USB. And it's basically when we were talking about using 2 Ovirals and then 12 hours later taking another 2 Ovirals. And so that had both estrogen and progestin, and it had a very high rate of nausea and vomiting. And the studies that suggested, did it work or not work, weren't all that good initially. It just seemed to sort of reduce the rates of pregnancies. So what this slide is showing that even if the USB method doesn't affect any, like even if it's useless and it does absolutely nothing, that Plan B is better. Okay, so Plan B will reduce it, will be effective at least to reduce the rates by 50%. Okay, so because you can't compare, most studies won't let you compare it to nothing. Like if you have an EC study, they won't let you compare Plan B to a placebo because the USB regimen is out there. You have to compare it to another type of EC or something along those lines. So we just can't get that study. So this sort of study shows that that the Plan B definitely does something. It definitely reduces your rate. But we're not 100% sure that the USB one does. So I think if you have a choice, like if you're in the middle of nowhere and you have nothing else, fine, you can use 5LS and 12 hours later 5LS, because that's pretty much all you have out there right now. But if you can, I would definitely recommend Plan B over. So what are some of the lessons learned? Basically, what's big in red there is ECPs are not used frequently enough. So they underestimate the risk of pregnancy. They think, I'm not at the time of my cycle where I'm at risk. And so even if you counsel them appropriately, they may not be taking it when you think they should. So now I'm just going to go to what do you do when you have someone who comes to you for their first, they want to start on a birth control method. And part of the thing that we ask them about is, have you had unprotected sex recently? So you can give them an ECP, but then start them on a birth control method right away, or you can wait till they have a period to make sure they weren't pregnant. The problem being they could have more episodes of unprotected intercourse and think that they're safe because they've taken ECP. So I recommend, this is the regular start I recommend, so the quick start method or the rapid start method. So regular start, you use back up to your next period, and you start the contraceptive method according to regular patient instructions. But the quick or jump start method, you take your ECPs, but then you start your contraceptive method the same day. Okay, so if they're here, you put the patch on them at the same time you're giving them the Plan B. We have Plan B in our office, so if we think there's a better chance they're going to take it, we give it to them right then and put their patch on, or they put their ring in or whatever they need to do. And then they use backup for the first 7 days. So at least, so they should use condoms or some other birth control method, because it takes a while for their OCs, their pill patch ring, in pretty much everything we do, takes about a week to take effect. So initiating, condoms use immediately, spermicides immediately, diaphragm immediately, implant. So the issue with the implant and the levonorgestrel treater system is you want to make sure that if you had a levonorgestrel IUD, because it doesn't work as emergency contraception, you have to wait till their next menses before they do it. So you could always give them a NuvaRing or a Depo-Provera shot, and then bring them back in within so many times to get their implant or to get their levonorgestrel IUS. But you shouldn't be putting their implant or their levonorgestrel IUS in as a quick start method. And then copper IUD, I'll mention a little bit more later. So side effects of Plan B, nausea is in 23%, vomiting is in 5.6%, and then the other side effects are things like dizziness, fatigue, headache, bloating, abdominal cramps, that kind of stuff. And most women will have their menstrual period within 3 weeks of their Plan B, so they should do a pregnancy test if they haven't had their period within 21 days as part of their instruction. And again, remember, if you're putting them on a pill, that might delay things a little bit. So the copper IUD, so the ones we have in Canada, the Liberté, so that's about $60 or so, I think. Flexi-T, maybe $80 to $100. Nova-T, I've seen more around $150 to $180. Okay, so these are good ones in terms of what the cost might be to the patients, and many of you have clinics where you sell them at cost to your patients. We don't have that option. We either give it to them, or we have them go and get a script and go somewhere and pick it up. So we, as I said, don't use Mirena for emergency contraception because it won't work. They have 7 days of unprotected intercourse. Do a urine pregnancy test before insertion because you don't want to insert it if they're already pregnant, and because it's not going to affect, it can disrupt a pregnancy. It can cause an abortion if you put in a copper IUD. And then there should be no history of a recent PID, no risk for STIs, and no evidence of current vaginal or cervical infection if you're going to use this as an option. I've been here for 7.5 years. I have never put in a copper IUD for EC. So I think that's going to be more of a community setup, and you obviously can't refer, because I just can't get them in that fast. So this is going to be something where you're in the trenches and you're basically seeing them, and you have to keep that in mind. So I think the main thing about the copper IUD is that it's 99% effective at preventing pregnancy. So if you have someone, obviously it's not something you would use in someone at risk for an STI who's, you use Plan B for someone who's been raped and that type of thing. But if we could get it out there in those community centers and advertise it as something that's available and that it's an emergency, they've got to get in within 7 days and actually insert it, it's way more effective at preventing pregnancy than our Plan B. Our Plan B is just much more accessible. And then the possible complications or side effects are the same things: perforation 1 in 1,000, expulsion 6%, pelvic infection, and again, that's why you do at least some sort of visualized screening to make sure they don't have an infection, and some bleeding and pelvic pain because it's a copper IUD. Okay, so I hope that so just in summary, I think for EC, the big things that I do now is I give them their EC and I start them on their birth control method. Okay, so you got to figure out how you would do that for each of the things. We give them Depo. We give them both Depo and the Plan B right at the same time. We start them on their patches right at the same time. I agree it's a good amount of hormones that they're getting. They might feel a little bit more nauseated than they would have otherwise. But if you wait for them to get that next one, I think you're going to get a lot more pregnancies. And it's a good opportunity to kind of, they're coming in for EC. It's a good opportunity for you to do both things at the same time and try to get them as quick as possible. As I said, if there's anyone out there that can offer an IUD within a week of unprotected intercourse, that's great. We just don't have the setup where we are to make appointments that quickly. So I think that has to be some of the rapid access clinics than what we have. And unfortunately, advanced provision and explaining doesn't seem to make a big difference with populations, but it may still make a difference. I think it can still make a difference for an individual patient who comes to you and says they need it. I don't think that the message should be, it's not going to actually work for you this time, because they're coming to you, and it has been shown to decrease the risk for that time that they're coming to you. But as a population, giving it out in advance hasn't seemed to be working to affect, because a lot of women aren't using it when they should be, even despite counseling. Okay, so I wish I had a better message for EC, but
there's always a ways to go. There's always a ways to
Yeah.
go. Okay, we'll stop and give some people time for questions. I don't know, we'll give the rural sites another chance. Certainly, I would like to thank everybody for coming. And we, when we emailed this out, we sent out an evaluation. And if you have them with you, if you could fill them out, and I think there are instructions at the bottom of that evaluation form. So if you can send it to Deb Valaton, we're absolutely interested in hearing your feedback from this session or suggestions for other sessions in the future, and that will give us some information to promote this as we need to. Okay. Maybe I'll wait. I was told to wait a few seconds to give them a chance at the other sites if there are any questions at all. Okay, go ahead.
If you're using an IUD insertion for EC, Is there an increased risk for ectopic? It wasn't listed as one of your comments, because there is a risk for it just with an IUD. I just wondered if it was increased.
I don't think it's increased from the general population. Like it's supposed to be 20% for an IUD. I don't think it would be any higher. But I haven't. I think because it's 99% effective, I think that you just don't have the numbers to say. Is what I would guess.
Okay, thank you.
Okay, we'll look around for other questions. Put the bug in, and also please sign the attendance sheets. I think we have had one circling here at this at Fred Gaspard Theatre, and if you haven't signed it, please we'll locate it and have signed it. And also same with the other sites around Manitoba. And again, if you can, it should say at the bottom of there to forward it to Deb Valaton, and then we'll have a chance to know how many people showed up. Okay. There must be some questions. Perhaps not. Okay. Well, that's fair. Certainly, like I mentioned earlier, we have the guidelines are available on that website, www.serc.mb.ca. And of course, also there is the SOGC website, which was an enormous resource for us as we went forward and wrote these and adapted them to nursing practice. So we're eternally grateful for those ones. But I am going to turn it over to Pat Martin, who is going to do just a bit of a wrap up for us today. Okay,
Sure.
Pat.
Do you mind if I just add one thing before?
Absolutely. We're doing so good on time.
In Appendix A, if you look up the U.S. eligibility criteria for contraceptive use, there's some new guidelines that came out in 2010, and they're really handy. I've got a sample of them here. If you look up under morbidity and mortality weekly report in the United States, you can access it online and print out the appendixes that show basically it kind of simplifies it into no problem using the method, risks outweigh benefits of using the method, the benefits don't outweigh the risks of using the method, and just don't use the method for many different things that, and I use this on a daily basis for things like migraines, breastfeeding, all kinds of stuff, gallbladder disease, transplants, everything, bariatric surgery, everything you can think of. So if you'd like to take a look at that, I think that's something new that's come out in the literature that really helps. It has some basic stuff, but it's really helpful for the population out there. And then the other thing is just if people did want to ask questions in the future, I guess, I don't know if they want to contact you or contact me, or if there was a way to have some kind of forum, I think that would be really helpful. So that when there's questions in the community, that we could review them.
That's certainly something we're absolutely working at, and I think Pat's going to address that now.
Excellent.
Maybe I'll just copy that from you, and then we can always send around the.
Okay.
I'll copy the name of the appendix, and I know where to get it, and then I can send it around, and it can be accessible to everybody to refer to. Okay.
Oh, sorry, I have one last thing too.
No worries.
Diaphragms. Does everyone think we can't get diaphragms right now?
Well, I'd like to know where.
Okay, so there's Milex. Milex now has diaphragms that you can get. This has come up pretty recently. If you go to like a Shoppers Drug Mart or a pharmacy, they should be able to order it in for you, but Milex is the people that have something right now. And then what you have to use is something called Contragel, which is a spermicide that's not Naloxone 9 based. And that's so that's what they recommend using with these types of diaphragms. So for years I couldn't get diaphragms for anybody, and now we can. These are we can always put that out on the website.
Okay, so M-Y-L-E-X or M-I?
M-I-L-E-X.
Okay, M-I-L-E-X, Milex, and Contragel. Go ahead. Oh, but and I'll just repeat it. Go ahead.
Who fits them now?
The question is, who fits diaphragms?
Whoever did before. I mean, it's only been out for a year or two. It hasn't been that long to.
Yeah, a lot of places don't. I know community health centers, they don't even have fitters.
Yeah. So if you contact your Milex rep, then they can get you the fitters now.
Okay. The question was about who fits diaphragms, and
But it hasn't been off that long. I'm hoping,
Yeah. So
that
yeah.
if you just get the diaphragms, you'll be able to then fit them the way you used to.
So if you still have the old ortho or whatever.
Yeah, exactly. It's still going to give you the size. The other thing is there's a new one called Silks that might become available in the next year or so that patients can fit themselves. So that's something, SILCS. So there's stuff coming down the line, but it's not here yet. But keep an eye out that they probably are just going to have you go to the pharmacy and you pick it up yourself. One size fits all.
The ever-evolving world of contraceptives.
Yeah.
Okay. Well, Pat, I'll turn it over to you, unless Dr. Pymar, you have any third last
I'm done.
things. Okay.
Thank you.
Great.
Okay, thank you very much, Dr. Pymar, for an excellent presentation. You've provided us with a wealth of information, and a lot of it is very new information. And as Diane mentioned earlier, I'm sure that there will be a number of questions come forward as people have an opportunity to mingle a little bit after and do a bit of discussion. So what we're going to ask is that if anyone has questions that they haven't had an opportunity to ask today, if they can just send those questions through to Deb Valaton. And as Diane mentioned earlier, she is at the top of your evaluation sheets and also was the person that sent the invitation out. And what we will do then is ensure that those questions are all recorded and the responses to them, and we will send them out to all of the participants that have joined our teleconferences, both this one today and our first teleconference. Today marks the conclusion of the rollout of the guidelines for the delivery of contraceptive health services by RNs. You will be receiving an invitation in June to complete an evaluation for these guidelines through a SurveyMonkey process. Following the completion of the evaluation, a report will be completed and sent through to HIPSN. Also, as well, there's discussion currently going on underway with Manitoba Health, MAX, and Healthy Child Manitoba regarding what a long-term plan might look like for to ensure that these guidelines stay current and continue to address new and emerging issues. There's also been some discussion around the whole area of how regions might continue to share information and best practice learning in relation to sexual health issues as well. So those are two pieces that we hope to be able to share some more information with you on. We will utilize the contact list that has been built from the 2 telehealth sessions to keep everyone informed of the outcomes not only of the evaluation but the discussion that is currently underway. And each region will be receiving a CD copy of the keynote speakers from both telehealth sessions, and we're hoping that that will happen over the next 4 to 6 weeks. As Diane had mentioned earlier, both to the sites in Winnipeg and the sites rurally, please complete your evaluation forms for today's session, as that information will be captured in the final report that will go through to HIPSN for this project. Also, please ensure that you've signed the telehealth sheet and have someone designated at your sites rurally to return that to Deb Valaton, because that will become our list to send out future information in terms of best practices or invitations to more education. So on behalf of the steering committee, I would like to thank everyone both at the Winnipeg sites and across the province of Manitoba who have joined us for the rollout today for these guidelines. And again, thank you all for your commitment to the delivery of sexual health services to our clients and our population across the province. I would also like to take the opportunity at this time to extend a special thank you to the steering committee members who have worked tirelessly over the past 3 years to see this project through to completion. Finally, as Diane had mentioned earlier, just again to remind you that the current versions for these guidelines will continue to be posted on the CIRC website, and Diane gave you that website a little bit earlier. So if there are no further questions today, thank you to all the rural sites and to everyone in Winnipeg. Again, thank you very, very much, Dr. Pymar. It's been an excellent session today, and you brought a lot of new information to us. Have a good day and drive safe to everyone.